Hello and welcome to this PCR webinar supported by an educational grant from Boston Scientific entitled The Clinical Impact of TAVI Frame Under Expansion and Optimization Strategies. This is a very contemporary topic, as TAVI has fully matured and evolved to become the dominant treatment for patients with severe aortic stenosis. As such, in 2025, we are aiming for perfection in our TAVI procedures as we think more about the long-term results from our interventions. Our topic today is also broad, with adequate stent expansion being relevant to not only one particular valve type, but all transcatheter heart valves, regardless of if self-expanding or balloon expandable. To help us navigate the data and procedural challenges, I'm delighted to be joined by our webinar guests, Professor Wong-Kun Kim, Professor Marit Grieger, and Dr. Arif Koka. Welcome, gentlemen. Thank you for joining.
Thank you for the invitation. Yeah.
This is your session, so please do interact and ask any questions along the way by posting using the Slido link, and we will always prioritize your questions and answer them directly. So over the next 60 minutes, we are going to achieve together the following learning objectives. Firstly, we are going to understand the longer-term clinical importance of TAVI frame under expansion. Secondly, together we will discuss contemporary TAVI procedural practice, focusing on TAVI frame under expansion. And lastly, you will be able to develop your optimization strategies for addressing this clinical problem. So now, to begin proceedings, it is my pleasure to hand over to Professor Kim, who will be focusing on accurate prime under expansion, including exciting data and procedural optimization techniques. Professor Kim, over to you.
Thank you very much. It's a pleasure to be here and to be with this excellent panel. Chris, as always, very eloquent introduction, and I'm happy to have the part to introduce you with the following two learning objectives. And the first one is I would like to provide you with an overview, with a compact overview on the study outcomes of clinical impact of midframe under expansion following TAVI using a self-expanding transcatheter heart valve, which we have, which has been published recently in JACC Intervention, and describes the incidence, how to detect under expansion and the clinical impact on under expansion using the accurate Neo2. And then in the second part, I would like to elaborate on how to optimize the TAVI procedure in only a few slides, and only to emphasize the most important steps if we use the accurate platform. So let's start with the study data, and we all have seen the data were presented. I don't think they are yet published, but we have seen the data of the accurate IDE trial that were presented at TCT last year in November, and we have seen that the accurate Neo2 did not meet non-inferiority in comparison with the control group, which was either SAPIEN or Evolut prosthesis, and the selection of the prosthesis was at the discretion of the operator. And what we found is that in a post-hoc analysis of the IDE trial, that midframe under expansion could have played a major role, occurred in 20%, and was associated with adverse events at 1 year. And if you compare those among accurate Neo2 recipients that had under expansion versus those without under expansion, you could see that those without under expansion had similar outcomes as in the control group in terms of death and stroke. And additionally, these data stood in contrast to what we have seen in the European experience, showing here comparison from 3 German high-volume centers, accurate Neo2 versus SAPIEN 3 Ultra, a total of 2,000 patients, propensity matched, and the primary endpoint, and it was the same endpoint as used in the IDE trial, the composite of death, stroke, and rehospitalization was similar at 1 year. The same recently presented at CRT by Andreas Rück, Sweetheart data comparing Accurate Neo 2 versus Evolut and Sapien, showing likewise no difference in terms of the composite endpoint at 1 year. So this contrast and also the occurrence of underexpansion drove us to further analyze European data. And this is what we did from 2 experienced high volume centers. And we wanted to assess the incidence and the impact of underexpansion on clinical outcomes. And this is what it looks like. The underexpansion was identified on fluoroscopy. And here on the left-hand side, you see an accurate valve without underexpansion. You can see that the stent posts, the commercial posts are parallel, but the extended line do not cross. And on the right-hand side, you see an example of underexpansion indicated by non-parallelism of the commercial post. And those patients that were identified as underexpansion were assessed in terms of the primary endpoint, the same as that was used in the IDE, all-cause mortality, stroke, and rehospitalization. So here you can see the study flow chart, and we were able to include a total of 604 patients implanted with the Accurate Neo 2 between 2020 and 2023. And after initial deployment, and you can see what it looks like, this is step 2, we were looking at around 1/4 of patients that had mid-frame underexpansion, 3% were not evaluable, and around 74% had no evidence of underexpansion. When we perform post-dilatation, and it is important to emphasize that at that time, we were not aware of what mid-frame underexpansion looks like, and perform post-dilatation mainly for PVL or increased gradients, or in the presence of very severe malexpansion. And so you can see that in both groups, post-dilatation was performed, both in those without underexpansion, and this was, in this group, it was around 100 patients, and again, this was for PVL or increased gradients. But also in the group of patients that had initial mid-frame underexpansion, post-dilatation was performed in around half of the cases, so 65 patients, and you can see that after post-dilatation was performed, most of the patients, mid-frame underexpansion could be eliminated. So at final assessment, we saw underexpansion in around 14% and no underexpansion in 86%. If we look at characteristics of the patient population, and this is one summary slide for time reasons. Just at one glance, baseline characteristics were similar between both groups. There was no difference, and especially in terms of calcification, no significant difference. Also, procedural metrics were comparable: valve size, pre-dilatation, balloon size, implantation depth, etc. And also, this is quite interesting, that most in-hospital outcomes, especially technical success, device success, and mean gradients, were similar between the two groups. Now I will show you what was different. And we saw a major difference in terms of post-dilatation rates. Those patients that had mid-frame underexpansion had a post-dilatation rate of only 8%, versus 34% of post-dilatation rate in those patients that had no underexpansion. Also the balloon size was larger in those patients that had no underexpansion. There was some signal that commercial misalignment could have played a role. And what we also saw is in the early phase, there was a signal for higher stroke rates when there was mid-frame underexpansion. And here I would like to present the main outcomes. This is the primary endpoint. And again, this was a composite of all-cause mortality, stroke, and rehospitalization at 1 year. And you can see, and even though there's a relatively wide confidence interval, there's a very fast segregation of the curves within the first few months, and keeps on segregating over 1 year. And I think that this is mainly driven by stroke that increased over the first 3 months, and also driven by mortality that had a maximum peak in the last 3 months. Rehospitalization was also significant, but probably not a strong driver. So looking at the next slide, here you see the effect of post-dilatation. And I already mentioned that among those patients that had initial mid-frame underexpansion, only around half of those patients underwent post-dilatation. But we could see that after post-dilatation, mid-frame underexpansion could be mitigated in most of the cases, in 90%. And in some of the cases where post-dilatation, where underexpansion remained, the balloon size could have been chosen larger. So there was a very strong effect of post-dilatation, and you can see that also in terms of the primary endpoint, those patients, among those patients that had initial mid-frame underexpansion, outcomes were significantly better if they received post-dilatation versus those patients without post-dilatation. On the other hand, among patients that had no initial underexpansion, when we perform post-dilatation for other reasons such as PVL or increased gradients, there was no downside, no trade-off of performing post-dilatation. So now I would like to switch to the second point, and this is more practical, and in a few slides we will try to describe how to optimize the procedure, also in the with the background of the new data that we have. And I think that we all know that accurate requires an effective pre-dilatation, and we should be aware of the fact that the radial force itself is very comparable between all self-expanding platforms, but the opening force is a little bit different. And what we need to take into consideration is that we have a top-down deployment. So we need to have a very effective pre-dilatation, and I think that there could be a paradigm shift, just like we do in PCI. And here you see a case with a very calcified anatomy. The first balloon inflation, you see there was an indentation also in the second inflation, and just after the third inflation, you can see that the indentation was gone. So I think there needs to be a shift to a more effective lesion preparation. Also, positioning in parallax is important in order to prevent pop-outs or micro dislodgement. Appropriate sizing. Here you see some examples of what it looks like if you have parallax. The wire position plays a role. There are other factors that need to be taken into account, and here you see that there's a pop out, and this is very important. For time reasons, I cannot elaborate too much on that. So what is important also in the context of the data that we have, I think we should be aware of what underexpansion is, being aware of the clinical impact that it can have. And this is very important to see and to differentiate between mid-frame underexpansion, and this is what happens here in this region where also the leaflets are, and you can imagine that there is a strong impact on on leaflet function, whereas here you see an example of inflow under expansion where probably leaflet function is less affected. Here's a very interesting case example. This was a quite calcified case, effective ballooning, and this was the first result with still a leak. The operator was hesitant to perform post-dilatation, so I recommended looking at the en-face view. And you can see that on the en-face view, there's an indentation, and it exactly looks like this, what we have recreated on the bench with under expansion. And so post-dilatation was performed effectively. There was no issue, and after post-dilatation, you can see very nicely in comparison to the previous expansion state that I think that the indentation or the infolding was gone, and we had a very good outcome. And I would say if you look at different degrees of what under expansion can look like, here's a very extreme example. I would say that we didn't achieve a perfect result with a circular shape of the prosthesis, but I think that there was a major improvement. So regarding post-dilatation, I think I've shown you that post-dilatation is essential if there is under expansion, and overall we have a lot of data showing that post-dilatation is safe and effective, but there always should be an individual risk and benefit consideration. And there are some aspects to be looking at in favor of post-dilatation, or rather to be careful with post-dilatation. There are different shapes of the valve, also the position. I think what is very important is the contact area. If the contact area is large of the prosthesis, it's probably very safe to perform post-dilatation, but this remains an individual decision. So I would like to summarize. We have shown in the European real-world practice using Accurate Neo2 that midframe under expansion occurs in 14% with the method that we use. When we used the same method as in the IDE, it was only 9.4%. So it was less frequent than in the IDE trial, but nevertheless, there was an impact on clinical outcomes, and the absence of post-dilatation was the only independent predictor of under expansion, was associated with worse outcomes at 1 year, and post-dilatation is effective to mitigate under expansion. And in terms of clinical practice, I think we need appropriate pre-dilatation. There's a paradigm shift. It becomes PCI-like. Post-dilatation should be considered, and this is what we knew already in PVA, increased gradients, but also if there's evidence of under expansion. I think it's safe. This should be an individual risk stratification. I think we should have a low threshold, and importantly, I don't think that we need it in 100%. Maybe it's required in 40 to 50%, depending on the patient population. So I think there should be an awareness of what midframe under expansion looks like, how to identify it, and how to treat it. Thank you very much.
Thank you very much indeed. I mean, that was such an enlightening talk. You took us through all of the new data, and then you finished off in the second half with some fantastic procedural tips. What I really picked up on there was how we're introducing this new paradigm in the TAVI space about how best practice we use in coronary angioplasty, specifically lesion preparation, safe implant, and then post-optimization as needed, is increasingly becoming more common and indeed indicated in our TAVI procedures. So thank you for that. So I'd like to open up the discussion now, actually. And Marek, I'd like to direct a question to you. So can we discuss the potential mechanisms by which we think stent frame under expansion may lead to the adverse clinical outcomes that we see, particularly stroke, potentially even mortality?
Marek, we don't hear.
Unfortunately, we don't hear you, Marek.
You don't hear me?
We do now.
Can you hear me now?
We can, yes.
Yes.
Yeah, okay, sorry for that.
No problem.
Yeah, so there are two potential mechanisms. I would say that there are some short-term mechanisms and there are some long-term mechanisms. In short-term mechanisms, I think that non-laminar flow, turbulent flow, and reduced washout in the leaflets may lead to platelet activation and then to developing of microthrombi and microemboli. And that leads to what was observed as it was presented by Kim to higher rate of stroke and death. But for me, it's a short-term mechanism. But there is also a long-term mechanism, which I think it's also important because that under expansion may be associated with more severe patient prosthesis mismatch. It was not shown here in the data presented by Kim, but potentially it could be one of the mechanisms. Then, because of a pinwheeling effect, it may be also associated with poorer long-term durability of that valve, potentially also with the commissural misalignment, and these all factors may lead also for the difficulties with subsequent potential valve-in-valve procedures. But so far we know the data for the 12-month, and these 12 months data, I think that non-turbulent flow associated with frame under expansion is a key mechanism leading to that development of microthrombi.
Thank you, Marek. I think you're absolutely right. And I think what's nice about these types of theories is, there's clear biological plausibility in this. And I think in many respects, the recent data from the IDE trial has opened our eyes to these types of issues and has contributed massively to the TAVI field and the types of optimizations that we're now performing. So thank you very much for that input. Arif, I'd like to turn my attention to you now, if I may. And you are an expert and have great experience in simulation-based modeling. And I just want to ask the question, from your work, do you think stent frame under expansion is only a consideration for particular THV platforms, or do you consider it relevant to all valve types?
Yeah, thanks, Chris. I mean, that's a good question because this has become a hot topic after the IDE trial. Actually, and as we'll show later on with some of the bench testing, under expansion applies across all valve platforms. There's been lots of studies which have shown it with all cross self-expanding platforms, but also balloon expandable valve platforms. Raj Makhar's group from Cedars-Sinai have actually led a lot of data and shown a lot of good data showing balloon expandable under expansion in quite difficult scenarios, such as bicuspid, heavy calcification, or even valve-in-valve settings. So there is something about needing to understand the valve that you are treating and then being aware that you are going to possibly encounter under expansion, irrespective of the valve technology you have. Then I think the second thing which Von showed very nicely is evaluating this mid-frame under expansion. Now, these are new words for us. Inflow, we were maybe familiar with, leaflet level, okay, mid-frame under expansion. So it's clear that even though it affects all these different valves, each of these different valves probably has a different signature. And we'll come back to this point of this particular signature for each different valve to know when it is likely to be underexpanded. So in conclusion, I'd say it affects all valves. It's more important to understand the anatomy and the phenotype that we're treating to know when we might get this. And then we as operators, particularly if we're using different valve platforms, need to know how can I identify underexpansion for this valve I'm using.
That's such a great point. It's not just specific to the valve, is it? It's also its interaction with the surrounding anatomy. And I know you've got some wonderful illustrative examples later in this webinar, so we look forward to that. Okay, and Professor Kim, we've actually had a brilliant question that's come in from Renee, who's watching online. And it's a very clinically focused question that I hope you can help us with. And it says, if after valve deployment, you don't have any paravalvular leak and you don't have any significant gradient, but the accurate Neo2 or indeed prime posts are not parallel, so mid-frame under expansion, would you still go ahead and post-dilate it?
This is a very good and very clinically relevant question that we always have to ask ourselves. And I try to emphasize that it's always an individual decision that we have to make. But I think traditionally, We had the indication for post-dilatation in cases of PVL. There's no question. We need to eliminate PVL and increase gradients. That was very clear to us. But under-expansion is a new term that we have to learn and incorporate in a clinical workflow. And you could have the scenario, an 85-year-old lady. This is very, very critical. We are glad if the case is going well without any complication. We have done pre-dilatation and no gradient and no PVL. So everything is fine. And everybody says, this lady is 85 years old, please, we do not touch upon her, no post-dilatation. But what we have to keep in mind is that the patient, they might experience stroke if we send them home with under-expansion. And we noted on the table that within the next few weeks or months, they might experience stroke. There's an increased risk of stroke, and we do not notice this risk in terms of device success, gradients, etc. But they are still at a high risk of stroke. So I think we really should incorporate this mindset of trying to achieve a very good index procedure in order to have sustained outcomes at the mid and long term. So I think this is, but always a very individual decision. For instance, if you have a very bad feeling, very shallow valve, then you can think twice whether doing post-dilatation, but usually I think the threshold should be lower, keeping this in mind.
Yeah, that's an excellent answer, because, you know, at the start of this webinar, we said we're aiming for perfection nowadays in TAVI in terms of thinking about those long-term outcomes. So that's great. And because the questions keep coming in, I'm going to stick with you, if that's all right, Professor Kim, and ask a question from Ahmed, who really liked the on-fast view that you showed of the THV, where you showed the under-expansion in a separate plane. So he wants to know, do you calculate it beforehand and utilize the TAVI CT for that?
Actually, that's a very good suggestion. I do not calculate it, but this could be taken into consideration. We are working with a Siemens workplace, and it's actually very difficult to get in those extreme angulations. But I've implemented the en face view in our clinical routine, and this helps for decision making. If I'm not sure about under-expansion from the parallelism of the post, it's not always crystal clear. It's a learning process, but I think if you look at this en face view, and if you are able to obtain this view, it's very, very helpful. And you will typically see some kind of infolding, as you have seen in this case example. And I think if you see such an infolding, it's a very clear indication that post-dilatation should be performed. But it's not only you know, this fluoroscopic view that we have used in this study is only an indicator of under-expansion. You could use different kinds of imaging, also TE or ICE if available, even TTE. And if you can note some kind of under-expansion infolding, then it is already very helpful. But I think this en face view is very, very, very nice to have, very easy to recognize.
I think, you know, this is a developing field for all of us, isn't it? And I can tell that from the questions that are coming in, because they're still coming in. So Marek, I'd like to stick with the audience questions, if I may, and ask you one from Diogo, who poses an interesting question, which I'm not sure we know the answer to, but in patients where you have intermediate sizing, so you could either choose, so let's say, for example, a small or a medium accurate prime in this example, he asks what could be considered the worst consequence of that, in terms of, is residual paravalvular leak worse than severe stent frame under expansion? Do we have a hierarchy of these two negative procedural outcomes?
Thank you. I think that it's a very good and also valid from the clinical point of view question. And I'm afraid that we do not have a good answer for that question, because choosing the smaller valves, we are risking, as you mentioned, a paravalvular leak. Choosing a bigger valve, bigger size valve, we are at risk of the frame under expansion. So we have to learn more, and especially for these, let's say, I would say, borderline sizes, more careful evaluation, looking at VCT, trying to expect how the valve will expand. It's a way of behaving so far, because there is no proper answer. At least I'm not aware about that proper answer coming from the studies.
Thanks, Marek. I agree. I mean, certainly that's a brilliant question that promotes further research. So I think we can all agree the audience is warmed up. And that's thank you all for your great discussion so far. But let's keep things moving and hand over now to Professor Grieger, who will be taking us back into the cath lab for an exciting clinical case presentation. Marek, over to you.
Yeah, Chris, thank you very much. So I'd like to show you one of our clinical cases and to discuss with you how we are approaching patients like that. So it's a typical TAVI patient, more than 75 years old, with severe aortic stenosis, with severe gradient, patient who had a coronary angiogram before the TAVI, and it's quite recent case of that PCI LAD, of a proximal LAD, as I remember, was done as a preparation for TAVI. And here you have a CT assessment. So you have measurements both from the annulus, and that annulus measurements are quite crucial, because you can see here how the minimum and maximum and perimeter derived annulus size looks like. We are looking also at the LVOT, if it's not too narrow, if here these two values are quite, I would say, similar. Quite a lot of calcifications in that valve, and you will appreciate that during the case. And we are also observing how the sinus of the valsalva looks like, and sinotubular junction. So for me, they looks completely okay in that case. And also the coronary takeoffs are quite okay. They are more than 10. As you can see, quite huge calcifications also on the way to the heart, and here with the accurate, which is delivery system is quite flexible. It's a good choice, I think, to go ahead with the accurate prime. In fact, in that case, no significant problems with the access. And we, as always, calculate two views, and these two views are quite important for the valve implantation. So there is a traditional free CAS implant view, but also a CAS overlap view, which we are using not only for the assessment of the valve expansion, but also for assessment of commissural alignment. So in summary, the perimeter derived annulus size was 25.4, and with good coronary arteries take off, so we decided to go ahead to implant the accurate prime 27 millimeters valve, and it's according to that size chart, which you can see here at the down of that slide. And here there are a few points during the procedure which are quite important for the implantation of the accurate prime. The first one is that you have to confirm the implant view with other platforms, like with Evolut, with Navitor. We are not so paying so much attention to be really free cusp in one line. Here with the accurate, we are very precise with that, and checking if the projections which were assessed by CT are really in the cath lab. And then there is quite important how you position the guide wire here. In my practice, I use Safari L in 99% of the cases, and that wire must be in stable position, because in outer curvature of the aorta, non-right commissure, and in the ventricle, because that wire position is extremely important for the valve delivery. And we started from the initial angio. It was calculated, just confirming that 3 cusps are really in one line. And then for that valve is absolutely mandatory to perform a balloon pre-dilatation, and moreover, it must be effective balloon pre-dilatation. And the recommendation which I use in my clinical practice that balloon size should be 1 millimeter smaller than the perimeter derived annulus diameter. So in our case, it was 25.4. So we decided to use a 24 millimeters balloon. However, if there is a lot of calcification, we maybe downside that balloon, but only, let's say, maybe 2 millimeters from the balloon recommendation. And then, as it was mentioned before by the Kim, we are trying, and sometimes it's necessary to perform that balloon pre-dilatation a few times to achieve a proper dilatation of the native annulus, as you can see here, the proper position of the guide wire and pre-dilatation. And then we are advancing the system, and we are advancing the accurate prime valve and to the position in which we are trying to obtain the commissural alignment. And here with that valve, it's not the main topic of that, but it's worth to mention that the commissure posts are aligned to the delivery system markers, and with that, it's extremely easy to obtain commissural alignment. And at least to our practice, it's the valve with which we can do it in every single case. And there are some certain rules how you should behave if that commissural alignment is not if these commissurals are not properly oriented. However, we are aiming to 1-1-1 orientation, as you can see on the right side of the screen. And if you have like that, you confirm that alignment in 2-cusp view. And here we did it exactly the same. So first in 3-cusp view, we were looking at the 3 posts, and these 3 posts are okay. Then move the table to the 2-cusp view, and separating one of the commissures, one of the posts is in fact on the right side. And if we are okay, we are coming back always to the 3-cusp view and aiming for the proper implantation. And proper implantation is an implantation of depths of 5 to 7 millimeters, because thanks to that you are able to reduce the conduction disturbances, you can reduce the PVL risk, and also it's a good position for the best coronary access and potential valve-in-valve procedures in the future. So you can see here on the top of that screen that there is a certain marker on that delivery system, and that certain marker should be positioned in ideal word just at the level of the sinuses, and then you have 5 to 7 millimeters. The valve will be implanted like that. And if it's too high, you can advance that valve, and if you are too ventricular, then it's a risk of a malposition, and you have to adapt to that. And in our case, as you can see at the beginning, that marker was slightly above the annulus level, so we pushed that valve a little bit, and you can see now that marker is exactly at the annulus level. So at that time, we are going to the step number 1, and step number 1 is slow rotation of the knob number 1, and that slow rotation is making that the upper crown and the stabilization arches of that valve are opening, and we then confirm that it's still in the good position by the contrast injection. And if we are okay with that position, we are going to this step number 2. So we're removing the pin, and then with the fast movement of the knob 2, we are simply opening the lower portion of that valve, and it's the end of the valve deployment. Then it's quite crucial to withdraw the system, and with the system withdrawal, it must be quite careful. And then you are getting to the implant assessment. I always start with the X-ray assessment in 2 views, and here you can appreciate that the valve is underexpanded, and especially if you inject a contrast, it looks like that valve is in perfect position. There is no PVL. However, if we should go ahead with the balloon post-dilatation, and that decision about the post-dilatation is based on two factors which we know before the accurate ID trial. So the presence of paravalvular leak or the gradient, which is more than 10 millimeters of mercury. However, after the accurate ID trial, we know that there is also the third factor, so that is a valve under expansion. And how to identify valve under expansion? So there are certain rules in the accurate. So the first one, which was mentioned by Dr. Kim before, so there is non-parallel commissure post. And the other one, that valve is taller than is wide at the level of the upper crown, or inflow is wider than the upper crown. And to go ahead with the balloon for the post-dilatation, there are also some important consideration. First, the balloon which is used for the post-dilatation should be never bigger than the patient's anatomy. So you have to consider the annulus size, and there are also maximum balloon post-dilatation balloon sizes for each individual valve, as you can see on the right side of that screen, and these considerations should be taken into account. So in our patient, we decided that we use exactly the same balloon for the balloon post-dilatation. So it was 24 millimeters balloon. And you can see that after balloon post-dilatation, there is definitely an expansion of that valve. No gradient, no PVL at that time. We assess it also on another view. Usually I am doing it without the contrast, and if the posts are parallel and there is the frame of the valve is expanded properly, we are finishing that case like that. Thank you very much.
Thank you, Marek. That was a real masterclass. I mean, it showed every single step of the procedure, and it reinforced all of the learning points that we've been working throughout these last 40 minutes or so. So thank you for that. So Professor Kim, I mean, we've talked extensively, haven't we, about the need for pre-dilatation, particularly with the accurate platform. But what are the concerns and misbeliefs that exist out there regarding either the balloon size or indeed the safety of pre and post dilatation?
Chris, thank you very much for this important question. And you already mentioned that there are some concerns and misbeliefs. And one of the concerns is, of course, that we can create damage with a large balloon size. And for most self-expanding platforms, there's a recommendation not to exceed the minimum diameter of the annulus. I don't know where it comes from, because I don't think there is much evidence supporting this. But if you have any evidence, we can discuss this. I think the highest concern is annular rupture. In my practice, I've never seen annular rupture only due to pre-dilatation. I've heard of very rare cases. I think it's extremely rare. If you do not exceed the average annulus diameter with the balloon, and you have to take into consideration, if you use a Sapien, for instance, a balloon expandable platform, usually the size of the prosthesis is larger than the annulus size. So for 24.5 millimeter annulus, the recommendation is to use a 26 millimeter valve. So I'm not sure whether this is really justified. Of course, if you take a larger balloon, you may have a higher risk of AR, hemodynamically relevant AR, but I think it's rare. It's still rare, and in most cases, if you have a quick implantation, then it can be addressed. So in my practice, for the accurate, I'm relatively aggressive. The official recommendation is to use a balloon size that is 1 or 2 millimeters smaller than the annular size. It really depends on the degree of calcification, what you want to achieve. It should be, we should have a similar approach as PCI. For other self-expanding platforms, I think it's okay to have a moderate pre-dilatation, for instance, Evolut or Navitor, but this is mainly due to the concept of the deployment. The accurate is top-down, and the other platforms are bottom-up, and we have multiple resheathings and deployments, which is a pre-dilatation-like effect. For balloon expandable platforms, usually probably it's okay not to pre-dilate, depending on whether you expect difficulties crossing the valve. And this is not only dependent on the degree of calcification or severity of the stenosis, but also the angulation, horizontality of the anatomy.
Fantastic. I mean, I agree with absolutely everything you said. And I think if we were just simply sizing according to the minimal diameter, Marek's case there had a very elliptical annulus. And so you would be systematically under sizing your pre-dilatation. So that's just a really nice illustrative example. Okay, well, thank you once again for the lively interaction. And we've progressed through, firstly, the data, and secondly, the procedural elements. And now it's my great pleasure to hand over to Dr. Arif Koka, who will bring all of these themes together with some exciting and highly illustrative examples direct from the simulation lab. Arif, over to you.
Great, thanks, Chris. So essentially, yes, the plan is now to, in the next segment, to bring together everything that you've heard from the clinical side, from the research side, and really try to summarize this topic of underexpansion in TAVI using the unique insights we can get from bench testing. And some of the key principles I want to talk to you about are really what is underexpansion and these different patterns? What's the impact that we can see on the leaflets and particularly the valve function? How can we evaluate it? We've heard a lot about that, but I'll show you in a different way. And then ultimately the importance of addressing this issue. So fundamentally, we've got many different valve types, and they all vary in terms of their size, their shape, mechanism of implantation, location of leaflets. But the one fundamental thing that is common across all valve platforms is that they are designed, constructed, and they come out of the pack designed to be circular, concentric, and expanded to the nominal size. And yet, when we put these valves inside of patients, we achieve some degree of underexpansion. And this is something that is common across the valve platforms that we have, whether it's self-expandable or balloon expandable. And it's simply just a reflection of the interaction you have between device and host. You've seen really nicely in Marek's case that this was an elliptical annulus, and it's not so uncommon that the native annulus is never really circular. There's always a degree of ellipticity to it. Secondly, anytime metal hits calcium, you're going to get an interaction and you're going to get some degree of underexpansion. Now, we've known about this from the coronary field. We've been putting intravascular imaging catheters inside the coronaries, understanding we have stent underexpansion and then addressing it. And it's only now with TAVI that we're beginning to realize, but the principle of underexpansion remains the same. And underexpansion itself is not a binary concept. You don't either have it or you don't have it. It's clear that there's different patterns of underexpansion. So you can have this sort of concentric underexpansion, whereby you've got a circular or almost circular valve frame, but it's constricted from all sides. This, for example, would be severe, heavy trileaflet calcification. More commonly, you get this more eccentric pattern to your valve, whereby you have a minimum and then a maximum diameter of what should be a circular valve frame. And then perhaps more worryingly, or what we do see is this kind of indentation or this regional underexpansion, which can really affect one side and have an impact. And that's not it. You can also have an impact at the level of underexpansion you apply. So underexpansion can either occur at the nominal implantation level of these different valves, or the underexpansion can be applied at the leaflet levels. And the question really is, at what level of underexpansion do you start to affect and impact valve function? So let's have a look at the leaflets and how the valve performs. Here you see we have 3 self-expanding platforms, and these are normal functioning leaflets in well-expanded concentric valves. Compare and contrast that here to severe underexpansion across these 3 platforms, and you can immediately visually begin to understand and see how the leaflets not only look different, but how they function completely differently. If we look at that in a bit more detail, what do we see? Well, we have restricted leaflet opening for sure, which reduces your geometric orifice area. If you look in the top left, this is the ideal scenario, this sort of Mercedes-Benz type sign that you have with a very central coaptation point. This is what we want to achieve. Now contrast that on the right-hand side where you can see you've got impaired coaptation, you've got this sort of eccentric location of the coaptation point, which may go on to impact the blood flow, and I'll show you that later on. And if you look on the top right panel, what you see quite nicely, you see a real sort of fold in the leaflets. This is what's called as pinwheeling. And then just underneath, around 6, 7 o'clock, what you see are these creases inside of the leaflets. And it's postulated that these can lead to microthrombi, as mentioned by Marek earlier. So this is some of the issues that we see. And furthermore, what we note is that it also matters the degree of underexpansion that you have. So these are all underexpanded valves, but there's a clear difference on the left-hand side between mild underexpansion, and the leaflets pretty much look okay and they open well, to much more severe case of underexpansion where you can see a big and dramatic effect upon the leaflets. So the question is, when does it matter? So if we do hydrodynamic testing, so on the left-hand side, we've got a concentric, well-expanded valve, and we're gradually applying more degrees of underexpansion, going to quite a severe underexpansion. Well, there's really 3 things to note when we look at transvalvular gradients. The first thing is that at low levels of underexpansion, you don't really impact the gradient so much. There's not so much of an impact. As expected, as you start to increase the degree of underexpansion or the severity of it, you do get an increase in the transvalvular gradients. But finally, you don't really ever hit the sort of VARC3 criteria of 20 millimeters of mercury, which would constitute a sort of a failed procedure or technical failure of the valve. So what do we understand from this? Well, gradients might not be the marker of underexpansion that we may expect. So we've talked about this already in the clinical case. You implant a TAVI, you have no PVL, your gradients are okay, maybe even low double digits, but that doesn't mean you don't have underexpansion. You can still have quite severe underexpansion, and that's something that we need to be aware of when we're treating these valves. We see a similar trend when it comes to effective orifice area. Again, at low levels of underexpansion, not so much of an impact. You expect that as you increase it, you do get a reduction, of course, but really it's clear that hemodynamics are maybe not the only thing that might be important when we think about underexpansion. And there we can begin to understand when we actually study the particles and look at the blood flow inside of these valves. So here we've got nominal expansion, concentric circular valve. You've got this nice laminar flow with a central jet, good washout of the sinuses, and therefore you don't get much in the way of shear stress. Now compare and contrast this to this scenario, where you've got a severely underexpanded valve. Firstly, just look at the black and white moving image. You can see the leaflet at about, let's say, 2 o'clock, 1 o'clock. You can see the crease inside of the leaflet, how that's really impacted by the underexpansion that you have regionally. This in turn then creates a very turbulent, high velocity flow, an eccentric jet. You impair washout of the sinuses, you increase the shear stress on the leaflets. And we know from previous studies that this can lead to not only halt, but also leaflet thrombosis, which eventually may be the pathophysiological link between the increased rates of clinical valve thrombosis or stroke that we're seeing in the signals and the studies that, as presented by Prof. Kim. So it's clear it's a problem, but how to evaluate it? I want to come back a little bit to this idea of the signature. Each valve has a particular signature for valve underexpansion. You've seen this slide before. This is how to identify valve underexpansion, particularly with the accurate valve. Now look at it in this way. Both of these 2 things are looking at the stent frame. So you're evaluating stent frame here. And here what you're doing is you're evaluating the commissural posts. So we can talk about this for every valve, but just specifically focusing on the accurate, these are your 2 signatures to look at. So when evaluating frame expansion in the cath lab, we've got here, this is an aortic root. We've put a perfectly expanded concentric valve. If you go into a 3-cusp view, you'll see that the valve frame, the stent frame is nicely expanded. If you go into your cusp overlap view, again, you'll see it's well expanded. And that's obvious. You've got a nice circular expansion. If you look at a circle and you look at it from many different angles, it will always look the same size. Keeping that in mind, let's now apply underexpansion. So this is an accurate valve, severely underexpanded, but with good commissural alignment. Again, you go into your 3-cusp view, you see you're looking into the major axis of the valve, and you would say that, okay, my valve is pretty well expanded. If you then go into the cusp overlap view or right-left overlap view, you would suddenly see that underexpansion of the stent frame. And this just highlights that if you want to look at the stent frame in this particular case, then going to the cusp overlap view is where you would appreciate that best. Now, if we look at the posts, because remember, commissural posts is another way of looking at mid-frame expansion. Same scenario, same valve. You go to the cusp overlap view. This valve is well aligned. So by definition, you've overlapped two posts. You can see you can't really appreciate that you've got a non-parallel post. It's difficult. So what do you have to do? You have to rotate your C-arm, go to the three-cusp view. You get that 1-1-1 configuration, and now you can understand that one of the posts is not parallel. So in this scenario, posts were best assessed in the three-cusp view. But really, the message to take home here is that we need to know with these valves that we're implanting, what's the signature of underexpansion? And we need more than one projection, often orthogonal projections, but certainly multiple different projections. So finally, how to treat this issue of underexpansion? Well, I would actually start, and we've heard about this, prevention is better than cure. So of course, we've talked about doing pre-dilatation, the right size of pre-dilatation, effective pre-dilatation, but have a look here, just a small thing you can do in the cath lab. Three-cusp view, balloon looks well expanded, everything looks okay. As you just rotate your C-arm, going towards RAO or towards a cusp overlap view, suddenly you're seeing that indentation inside of the balloon. So you may not have appreciated this fact if you did this pre-dil in the three-cusp view. And if you go to the cusp overlap, you might realize, okay, I need to do either another pre-dilatation, if of course it's safe to do, or maybe use a different balloon. And the question is that you can see on the left-hand side, this is mild underexpansion, but on the right is severe underexpansion. But in the cath lab, we can't see sometimes so well, we can't see the impact on the leaflet. So when do we post-dilate? But luckily, this is again the signature. We need to know when do we have a bad situation in front of us. So if you've got mild expansion at the mid-level, your post will be okay. That severe extreme end is where you start to see all these different non-parallel posts and frame underexpansion. And finally, post-dilatation itself is not just enough. It's not a binary thing that I've done a post-dil, I'm now fine. Really, the message here is it needs to be effective post-dilatation. Look on the left-hand side, we've got a 25mm accurate prime. It's underexpanded, we're just rotating it. And you can post-dilate it now with an 18mm balloon, and you can see how the post-dil balloon barely touches the accurate frame. So you're not really going to achieve much in the way of an effective post-dilatation. Now on the right-hand side, you take a 24mm true balloon, and you can see how you really push and stretch that accurate valve to achieve an appropriate resolution of the underexpansion. And don't forget that this is nitinol. So this technology means that nitinol wants to take the shape that it's been told to take. And so all you have to do is to achieve the expansion, and then it will hold its shape. If we look on the inside, this is, you can see this. So we've got a 25 accurate prime on the left. It's underexpanded quite severely. You can see that an 18mm balloon really doesn't do much and doesn't have any impact on the underexpansion. Go on the right, you take an appropriately sized post-dil balloon, 24mm, and there you can see you achieve the post-dilatation, the valve is well expanded, and again, as I say, because it's nitinol, it'll retain its shape. So if I have to summarize maybe this segment, but also perhaps this section and some of the insights from bench, it's clear that valve underexpansion occurs. And what matters is to what extent it occurs and what pattern of underexpansion we have. And that in turn will be based on the calcification and the design of the leaflets. There's an impact on the leaflet structure and function, which can subsequently impact the actual blood flow and shear stresses. When it comes to evaluating it, we need to know the signature of the valve that we have and how it looks underexpanded, and you need multiple projections. And finally, it's the importance of an effective pre-dilatation and an effective post-dilatation with appropriately sized balloons, of course, if clinically safe to do so. Thank you.
Fantastic, Gareth. I mean, they say a picture speaks 1,000 words, and that really was the case there. And I know how much effort and work you and the engineers back in Galway put into helping us understand things in this simulation and visual way that really just changes the message so much. So thank you very much indeed. And I'd also like to thank the remaining expert guests for delivering their highly educative talks and contributing their thoughts and discussions to this really, really enjoyable webinar. And we'd also, of course, like to thank you, the viewer at home, as we've worked together to achieve our learning objectives. So in summary, we are entering a new, highly mature phase of TAVI with a focus on procedural perfection. And accordingly, this means preparing the lesion, efficient implantation, and effective optimization as needed. and this is now the new paradigm in contemporary TAVI. With that, we will draw this webinar to a close. Thank you very much for watching.